So if I was an audiologist who wasn't working in a cochlear implant centre, I would be looking to see which of the NICE guidelines I'm currently fulfilling. So the hearing needs to be equal to or worse than 80 decibels at one of 5 frequencies: 500 hertz, 1, 2, 3, and 4 kilohertz. Additionally, or if your hearing thresholds are not necessarily matching your functional hearing levels, so speech testing is significantly worse than what you're expecting, or if the child's development, whether that be linguistic, cognitive, or general development, is not in line with their peers and in line with their sort of hearing thresholds or what you're expecting them to do, then I'd be considering referring. Even if you've got sort of like a ski slope hearing loss and you've got really good access in sort of the low frequencies, but your hearing in the sort of mid to high frequencies is poor or hits 80, I would still consider referring, because there are definitely options out there for patients, such as an EAS or an electroacoustic component to cochlear implant devices now, that can be used. And a lot of the surgery is soft. So actually all the surgery, I believe that they try to do a soft surgery, so it's causing as little trauma to the cochlear as possible. As young as possible. Under 12 months is great. But I mean, I would say your outcomes are better the younger they are. So I'd want to stress that under 12 months old, I'd want the patient sort of to be seen so we can get the assessment sort of done, because the quicker you implant, the better their outcomes are going to be. So if it was me and I was working in a department that didn't have a cochlear implant centre, I would want to monitor a child who I'm thinking is starting to sort of progress more regularly than I would otherwise. I would be looking at changes, not necessarily just in audiometric thresholds, but also in speech tests and functional tests, and look at sort of how they're getting on at school. So as much information as you can get from all of the people that work with the child, so teachers for deaf, teachers, parents. Look at speech test results if the child is able to do that, whether there's been a deterioration in kind of what they're getting in terms of their responses. And I would think about referring earlier rather than later. I wouldn't necessarily wait until they hit the 80. I might think about referring earlier, or at least having those conversations both with parents and with sort of potential CI centres that I want to refer to. The information that we would like from the referring centre is an idea of the behavioural and objective test results. So if that's objective, I'd like to see an ABR or I'd like to see an audiogram. I need to know the middle ear status at the time of testing. That's really important, because if you've done an ABR or an audiogram with flat timps, that's potentially going to skew what their underlying hearing thresholds are. And it's helpful for us to know whether we need to do grommets at the time of an ABR or grommets prior to assessing. So that's actually really, really important. Additionally, we want to see the most recent hearing aid report with the setting that the child has been fitted with. Any kind of issues with regards to compliance is also really helpful. And if you have any information about the etiology of the hearing loss, that's also really helpful, because certain losses or certain types of issues are probably going to require us to intervene a little earlier. So if we're thinking about things like meningitis or certain syndromes that we know are going to be causing so profound losses, that's what we're going to want to potentially speed up sort of the referral process for those patients. I guess the most important thing is that the assessment is not a decision. It is a process in trying to find out where the child's hearing abilities are, and whether we feel that their current amplification device is able to provide them the ability to do the best of their ability at school, or whether we feel an implant is going to be able to help kind of bridge that gap a little bit. The way we do that here at Great Ormand Street is through a multidisciplinary team meeting. So our assessment process is typically a week, 3 days. We also do some scans. So we do an MRI and a CT and an ABR if required. If we've got some of that information, we may not necessarily need to do it. But especially for our younger ones, we tend to do all of that. It's helpful for us, for patients that are coming to us, to know that we, during the assessment week, they will be seeing lots of different professionals. So they will see audiologists, speech and language therapists, psychologists. They'll have a balance assessment to figure out a baseline of their vestibular function, which is quite different to other centres. They'll also be seeing at some point an ENT surgeon as well as our AVM. We also have access to teachers of the deaf, which are in-house as well, so there may well be a school assessment or a home visit that will help them to, or our team rather, to assess how the child is getting on outside of kind of the clinical space. But I guess the most important thing is that we're basically trying to put pieces of a jigsaw together to try to find out how the child's getting on and whether we can be of help. And the patient or the parents rather don't have to make a decision regardless of whatever we suggest or recommend. Patients don't have to take that on. They're more than happy to kind of get a second opinion or just say no, thank you.